Thank you for joining us for the OLY Foundation webinar, Introduction to LIFT-ECHO, Learn Intestinal Failure, TeleECHO, Introduction to Clinicians. My name is Andrea Guidi. I am the Executive Assistant for the OLY Foundation. Most of you are probably familiar with the OLY Foundation, but just in case this is your first experience, I'd like to briefly introduce the organization. The OLY Foundation, it strives to enrich the lives of those living with home nutrition support, both intravenous nutrition, sometimes called HPN or TPN, and tube feeding. We do this through education, outreach, and networking. The OLY Foundation was founded in 1983 by Dr. Lynn Howard and her patient Clarence Oley Oldenburg. Today, we serve approximately 20,000 members. All of our programs are free of charge for patients and their families. First, a few housekeeping details. The OLY you should see a toolbar on the right side of your screen. Click on the orange arrow to show the control panel. In the question section, you can type any questions you have for me or for the presenter. Please note we will not be responding to the hand-raising function in the control panel. We will answer as many of the questions as possible during the questions and answers period at the end of the presentation. We'll post a recording of the presentation after the webinar on the OLY website. Please note that we have muted all of the participants, so you don't need to worry if there is background noise where you are taking the webinar. Now for the presentation. In today's webinar, you will hear from Dr. Kishore Iyer, Director of the Intestinal Rehabilitation and Transplant Program at Mount Sinai Hospital, New York, is organizing the LIFT-ECHO, Learn Intestinal Failure, TeleECHO. This intestinal failure echo is a collaboration among experts in nutrition, gastroenterology, surgery transplant, patient advocacy, and insurers, as well as the ECHO Institute, University of New Mexico, Albuquerque, with the American Society for Parenteral and Enteral Nutrition, ASPEN, as a continuing medical education CME provider. By participating in LIFT-ECHO, clinicians may receive expert consultation and continuing education that may benefit the clinicians themselves, but it will also benefit individual patients' care. The establishment of a LIFT-ECHO network based on the ECHO model of care to share right knowledge at the right place and right time is expected to improve management of complex intestinal failure in the United States. It gives me great pleasure to introduce today's presenter, Kishore Iyer. Dr. Iyer is Director of Adult and Pediatric Intestinal Rehabilitation and Transplantation at Mount Sinai Medical Center in New York, Surgical Director of Pediatric Liver Transplantation, and a Professor of Transplant Surgery and Pediatrics at the Icahn School of Medicine at Mount Sinai in New York. Kishore is a Fellow of the Royal College of Surgeons of England and a Fellow of the American College of Surgeons. He has served on the Pediatric Committee and the Policy Oversight Committees of UNOS, United Network of Organ Sharing, and is current chair of the Ad Hoc International Relations Committee. He is also a past member of the Board of Trustees of the OLY Foundation. His current clinical and research interests are in the areas of surgical management of intestinal failure, intestinal transplant, and TPN-associated liver disease, as well as in mathematical modeling for complex medical decision-making. He has published and lectured extensively in those areas. We are thankful to have you presenting today. Dr. Iyer, I will turn the presentation over to you now.
Thank you very much, Andrea. Ladies and gentlemen, thank you so much for taking time off your busy schedules to join us for this webinar to go through a project some of you may have already heard a little bit about, and something that I am extremely excited about. As you will see, and I hope it will become evident very quickly, I have a distinct advantage in trying to champion this project. Success or failure with this project depends entirely on folks like you. So with that introduction and shifting the burden entirely to you, my dear audience, I'm going to try and set myself up to go through this talk. I believe I need to switch my screens. Give me 1 second. And I hope everybody can see this. Here are my disclosures. Predictable grant support, and I have advisory relationships with the pharmaceuticals in this area, and I'm a surgeon, but that neither of those disclosures is particularly relevant. I will share that we have received, the ECHO project has received a generous seed grant from Zealand Pharmaceuticals, which has allowed us to accelerate our launch ambitions. So many of you might be familiar with this, and I apologize if anything I say sounds either too basic or too advanced. Since I don't know precisely the interests of my audience, I'm going to try and strike a middle road. So my interest, my clinical interest, is in the area of intestinal failure, and I prefer a very simple functional definition for intestinal failure, which is simply the failure of the gastrointestinal tract to meet the body's needs for nutrition to support growth in children and for maintenance of weight and normal physiology in adults. Now, for practical purposes, and that is a little bit of a generous view, but one could view that these are patients with intestinal failure, but almost by definition have refractory TPN dependence. Many years ago, when I started life as an intestine transplant surgeon in Omaha, I might be dating myself here, 1999, 2000, it occurred to me very quickly that what intestinal failure needed was a multidisciplinary approach that incorporated simple nutritional strategies, medical strategies, in selected cases, aggressive surgical strategies for ensuring optimal outcomes. And if a program, if a clinician were to use these conservative strategies well and optimally, then perhaps intestine transplant could be avoided in the majority of patients, and perhaps this is open to some discussion and guesswork, but in my experience at least, if you take all comers with intestinal failure, with optimal multidisciplinary management, maybe somewhere between 10 to 15% of all patients might benefit from intestine transplant, and certainly not more than 20% of patients, even in a very aggressive setting. It occurred to me very early in this experience, as I was trying to gain knowledge in intestinal failure, that there appeared to be significant differences in the quality of care that patients with intestinal failure get. And you may notice through this talk that I use intestinal failure and short bowel syndrome somewhat interchangeably. And in my mind, they are interchangeable for the most part, except that short bowel syndrome, by definition, refers to intestinal failure that has an anatomical basis with actual loss of intestinal length. But nevertheless, for most practical purposes, intestinal failure, whether that be functional or anatomical with short bowel syndrome, has really similar problems irrespective of underlying etiology. For the most part, there might be some specific considerations. But what is the evidence that there is disparity in care? If you look at Europe, there are quasi-national intestinal failure centers in several of the Western European countries, in Denmark, in France. Even if these are not designated as such, intestinal failure care and care of patients on home parenteral nutrition tends to be centralized in these countries, with some at least soft evidence that there are improved outcomes on home parenteral nutrition. There's certainly an ability to track data much better and to report those data much better than we might be able to do in the US. On the other hand, intestine transplant rates in the US are much higher, and as I've gotten older, it has suddenly occurred to me that while we have been told for very long that surely US intestine transplant rates are higher because we do HPN badly, I'm certain now that that is not the whole story. And I think there are several European countries where intestine transplant rates could actually afford to be a little higher, but access to transplant is problematic in several European countries with perhaps the same problems for intestine transplant that we have perhaps with HPN. Certainly, there are national guidelines and registries, for example, those from ESPEN, BAPN in the UK, and when you look at similar US attempts, they're met with very limited success. This is my crude attempt at modifying a UNOS transplant map, as it were, highlighting the major intestine transplant centers. I took it a step further to incorporate the intestinal rehab centers. And before anybody says, oh, you missed my center in X, Y, and Z, this is a very crude attempt, but very quickly will highlight the fact that there are vast swaths of land where there isn't a good intestinal failure center, let alone a transplant program. And so if you go, for example, if you go west of the midline across the US, drop a line through Omaha there, and go west, you have to travel long distances. Montana, Idaho, North and South Dakota, there really are no intestinal failure centers, and is that at least part of the problem? When I put that map against a similar map of Europe, you suddenly think, wait a second, there may not be all that much of a difference, because if you go further east in Europe, after Poland, we don't really know what is there in terms of intestinal failure activity in Eastern Europe, and certainly in the very Western Europe, Spain, Portugal, there are very limited intestinal failure centers. And this should not be a surprise. These centers appear to correlate with population density both in the US and in Europe. So irrespective of what are the forces driving such activity, whether they're market forces, whether there's customer demand, consumer demand, that seems to be the prequel, if you will, to the establishment of intestinal failure centers. What does that have to do with ECHO? So ECHO stands for Expanding Community Healthcare Outcomes, and I'm going to let this slide dwell for 10 seconds. Anybody interested in finding out more for yourself, make a note of that website there. That's the website of the original ECHO Institute in Albuquerque, New Mexico. And it is just an amazing website full of information, both on the start of the project and today on the incredible global reach of, to me, it's fascinating, of one man's idea to solve a problem that he saw at grassroots level. So ECHO is the brainchild of Sanjeev Arora, who is a distinguished professor of medicine at the University of New Mexico in Albuquerque. And he launched this project to solve a problem that he saw with diagnosing and managing hepatitis C in New Mexico. So if I can take 10 seconds to digress a little bit, Sanjeev, and he tells the story much better, but when he started life now about 13, 14 years ago as a hepatologist in New Mexico, he realized very quickly he was one of only two, and at one point only one hepatologist in all of New Mexico looking after patients with the growing epidemic of hepatitis C. And at one point, the average wait time to see him if you had a newly diagnosed patient with hep C was about 10 months. He saw this to be a problem, and like one of those exceptional people, he went after the problem, trying to solve it in different ways. He initially tried a little bit with Skype and telemedicine, and then he quickly realized that that didn't change anything. The patients traveling long distances to see him were perhaps spared the travel, the time, maybe the money, but it didn't change the wait time equation. It was still, the relationship was only 1-to-1, and he was not able to crack the wait list to see him. That was causing him real angst. So the goal of the original project, ECHO, was to develop capacity to safely and effectively treat hepatitis C in all areas of New Mexico and to monitor the outcomes. And as a secondary goal, as this evolved and it became evident that this was potentially a workable model, he then wanted to develop a model to treat complex disease in rural locations and in developing countries. This is an important slide, and I must point out that Sanjeev has very generously shared many of these slides with me, and it's a recurring theme with the ECHO model. If you go to the website, in many years in academic medicine, and some of you, I suspect, are in academic medicine, in many years in academic medicine, I have not seen an academic project, have not seen an academic clinician be so generous of his prior academic achievements in the hope that others will take it even further than he could. So the four pillars of the ECHO model, A, B, C, D there, A for amplification. His idea was to use evolving health information technology to leverage scarce resources. And the scarce resource in this case is the scarcity of expertise, and even more important, of expert knowledge. And the idea that he had was, as an expert, he could share best practices to reduce disparity in care and therefore outcomes. And this he describes as his aha moment. He tells the story that what really made him come to this ECHO model and realize that telemedicine was not the answer, but this was the epiphany he had in trying to answer the question, how does one actually become a medical specialist? You go in as a general medical doctor into a hepatology fellowship now, learning liver disease. You really know no more than your peers in general medicine, and you see a patient with hepatitis C, you present the case to your mentor, you get feedback, you see 10 more cases, you get some didactics, this goes on for 2 years, and voila, you're a liver specialist. And so he thought that the model that he proposed would use case-based learning to master complexity. And ultimately, he was astute enough to also realize that he would have to monitor outcomes, and he would use a web-based database to monitor outcomes. So that's really a key slide, and the fundamental tenets of the ECHO model, as it were. And the steps he employed in doing this was he was going to train physicians, physician assistants, nurse practitioners, nurses, pharmacists, educators in hepatitis C. Notice, this is not restricted to physicians. Ultimately, this was open to all non-specialist clinicians who might encounter hepatitis C. They provided basic training to use relatively simple web-based software that has some names. And then with this, they set about conducting TeleECHO clinics, which are essentially virtual online clinics providing multidisciplinary care for patients with hepatitis C, in the hope that this would create what he calls knowledge networks. And they were doing case-based guided practice, and with each case and with more and more cases being presented, there was an exponential increase in the expertise of the pool of general clinicians attending these TeleECHO clinics that he calls learning loops. And of course, their goal was to collect data, to report outcomes, and to look at effectiveness of these programs. They looked at benefits to rural clinicians, and some of them might be obvious. They were providing no-cost continuing medical education credits. They were doing that also for nursing. And they realized something that is subjective, and the cynics among us might say, oh yeah, but the truth is there was some benefit that was perceived with professional interaction with academic colleagues with similar interest. Non-specialist clinicians in rural locations reported less isolation. There was truly what Sanjeev calls a joy of learning that they discovered as they set about these multidisciplinary virtual clinics. And this is an important slide. Look at that for a second as I take a sip of water here. But the larger panel in the middle is what they call the hub. This follows a hub and spoke model. And in fact, the central figure in that picture, if you can see my mouse, that is Sanjeev Arora. If any of you think I speak of him as a messiah, I truly think he is at risk of becoming such. So they are now at the hub. There's a virtual multidisciplinary team at the hub, hearing cases being presented from these different spokes out in the periphery. And spokes that are presenting could be a single person with a webcam and a laptop in a conference room like so, or it could be a couple of community health workers, or it's larger clinics somewhere else. But what's common to these spokes, these are non-specialist clinicians who, in this case, were involved with caring for hepatitis C. And for the academics among you, this is a paper I recommend. This was one of my early reads before I reached out to Sanjeev. Is a landmark paper in the New England Journal in 2011 reporting their outcomes with using the ECHO model. Now, this is a different perspective. This is from the hub's viewpoint, and what they have is a setup with a couple of monitors, some simple hardware, and they can see the various spokes. And here's an interesting thing that I picked up as I was doing the last webinar, which is that actually in this case, Sanjeev is doing a didactic, and that slide says clustering of poor prognostic factors in heavy patients. So you can see how this works. The spokes present a case. There's discussion among, I'm going to go back to the previous slide. Say, for example, this gentleman here might present a case, and cases are presented to a standard template. The presentation, let's say, takes around 15 minutes. For hepatitis C, it was taking much less. And then the whole group, not just the hub, but the whole group has an opportunity to ask questions, to discuss, to provide some feedback. And then to make this a truly learning experience, after all of the discussion and the data gathering is done and ideas have floated, the hub, composed of a multidisciplinary team of experts in Hep C, now provide recommendations one-to-one to the presenting spoke, and they then move on to the next case. And after all the case presentations are done in a clinic, there's a very short 15-minute didactic on some topic, in this case relevant to Hep C. So as I said, Sanjeev was very astute. He monitored outcomes, and they looked to see how well has the model worked. And this slide is quite outdated, but this is what was reported in the peer-reviewed papers that described the initial Hep C echo. This came in New England Journal, and there was a more detailed paper in Hepatology. They conducted a total of 700 hepatitis C TeleECHO clinics. They issued just shy of 80,000 hours of CME at no cost, covering Hep C and related liver disease areas. They then looked at efficacy. How well did this project work for community clinicians in terms of improving their skill level? These are rough analog scales, and you can see that clinicians reported much improved ability to diagnose, to assess severity, to treat following participation in the ECHO clinics. They looked at overall competence in terms of self-efficacy, and there were substantial differences suggesting improved efficacy in managing Hep C among the clinicians. They also looked at the views of participating providers, healthcare workers. How did they feel? Did they feel it improved their confidence? Did they feel it improved their ability? How was satisfaction? And without belaboring this too much, across the board, scores were very strongly improved after participation in ECHO clinics. And here was maybe a very important slide, and I know I'm still talking hepatitis C, but this is really proof of concept. What they really looked at, for those of you who are not familiar with Hep C treatment, SVR refers to sustained viral response, effectively a cure depending on the genotype of the virus. And you can see that the success of treating hepatitis C as measured by SVR was very similar when patients were managed by non-specialist clinicians supported by the ECHO model or by specialists at the University of New Mexico. There was really no difference in outcomes. There was one important difference. Not surprisingly, the ECHO clinics treated a much higher percentage of minority patients, presumably people in rural New Mexico, Native Americans coming from from distant sites, who are able to be treated through the ECHO model in their local communities compared to the need to travel to the specialist site. This is a very important slide. I alluded to this briefly. When you think about traditional telemedicine, which seems to be all the rage right now, the fundamental relationship of one specialist treating one relationship is not, one patient is not changed. There's a one-to-one relationship in traditional telemedicine. It might have advantages in some settings. If the patient's far away, if it's a straightforward follow-up visit, you don't really need to lay hands on the patient. You can talk on the phone, you can talk on a computer. Telemedicine might work just as well. But where there's a real shortage of expertise, what ECHO accomplishes is one single multidisciplinary team of specialists at a hub are able to share some or a lot of their expertise with non-specialist clinicians at different far-off sites. And these people in turn are able to treat a much larger number of patients perhaps than the one team might have been able to treat. So that's the fundamental difference between ECHO and telemedicine. So this, what Sanjeev and his team concluded based on the initial work with hepatitis C was that rural primary care clinicians can deliver Hep C care under the aegis of Project ECHO that is as safe and effective as that given in a university tertiary level clinic. And it did appear that Project ECHO improves access to Hep C care for New Mexico minorities. ECHO is now covering a breadth of areas. If you go through the slide, you can see really a variety of chronic diseases, things like antimicrobial stewardship, behavioral health, cancer. There are numerous cancer echoes. The American College of Oncology is very involved with this, and it has in fact become what's called a super hub where they train other people to do echo projects. Very successful diabetes type 1 echo being run out of New York, NYU, endocrinology echo being run out of Albuquerque. University of Chicago runs a very big hypertension echo out of urban Chicago, south side of Chicago. And this is interesting to me. The ECHO platform, and we don't need to dwell on it, but the ECHO platform applies to not just healthcare. There are now at least a couple of state public health education departments that are using the ECHO model to spread knowledge. A lot of echoes in HIV, AIDS, opioid use, palliative care, you name it, there's an echo. Big tuberculosis echo in sub-Saharan Africa and India. This was a paper that actually just recently came out. This is an echo project being run within the VA across the country, and this shows dramatically improved survival for veterans with liver disease using virtual echo multidisciplinary Hep C clinics. This paper has just actually come out. A map of the world showing the proliferation of echo projects, certainly in the US, but also in Latin America, South America here, Argentina, Uruguay, Venezuela has an echo, which I just noticed. As I said, Sub-Saharan Africa, the CDC has a couple of projects in Nigeria. Multiple echo projects in India right now, and the Indian government has recently, I hope it has nothing to do with the elections, but has taken a big interest in this as a means to tackling the burden of chronic disease, particularly TB in India. And in fact, the ECHO Institute has just gotten a $10 million grant to upscale early detection and prevention of pelvic cancer in women in India. Variety of successful echo projects in the Queensland area. So you name it, it's happening. There's an echo in Auckland. This is interesting to me. The ECHO Act was passed by the House and Senate by unanimous vote in December 2016, not something that happens very often nowadays. It was signed into law by President Barack Obama, and the Secretary of Health and Human Services was instructed to study the impact of Project ECHO on all these issues that you see here. And for those of you who might be interested, I suspect there are future opportunities for funding, as Uncle Sam sees this as a way to perhaps have a positive impact on chronic disease. Excuse me for 1 second while I take a sip, and I hope you like the logo we picked. My wife said to me, "Where's the stomach?" And it's a logo. So with all this as the segue, we have decided to launch the Lift Echo project. Our goal is is to spread knowledge in management of intestinal failure and TPN. So we're going to launch this project in May of 2019. I'm just going to turn around and look at my board. And in fact, our first echo clinic is scheduled. I want to say tentative because I'm still nervous, but I'm going to say is scheduled for May 7th, the first Tuesday of the month. Every echo project needs a physical host institution. That happens to be Mount Sinai in New York. We're going to launch across the US, and we can talk a little bit more about this depending on where you all are from. We intend to maintain a fairly strict fidelity to the original echo model. We've got a lot of support from Sanjeev and really the Big Echo Institute in Albuquerque, New Mexico. We've got an expert medical advisory board to guide us as we try and shape this project. And I'm going to take 10 seconds to let you write down that website. Don't be disappointed by it. It's just hot off the press. We launched it 10 days ago. So it's still in construction, really. But if you haven't already, I encourage you to sign on so that we can make sure you get announcements. And I hope you will be a part of this project and help us grow it and make it successful. So here's our project advisory board. I don't want to belabor this, but many of these people are well known. We've obviously got a core team here. As I said, through a generous seed grant from Zealand Pharmacy, we have been able to get seed funding to allow one of our research coordinators to be full-time on the ECHO project. Right now, we're not doing research, so she's a project coordinator, but our intent hopefully is to also answer some important questions. Kelly Tappenden may be well known to many of you. Marion Winkler, both are past presidents of ASPEN and have been active in this area. ASPEN, the American Society of Parenteral Enteral Nutrition, has been extremely supportive. The board endorsed this project unanimously. Michelle Spangenberg, the director of education and outreach, has been very involved from the beginning, and ASPEN has undertaken to provide free CME, CE credits, so nursing credits, nutrition, and pharmacy will be provided free of cost to the users, but the project will pay ASPEN cost for this. The OLY Foundation has been very involved from the beginning. We want to try and incorporate the patient perspective, the patient voice in this, even if the project is not directly open to patients. And then as we expanded the advisory board, John DeBase and Doug Seidner, two gastroenterologists who've spent many years looking after intestinal failure, and significant representation from the insurance and quality industries. Our plan is very simple, 2 clinics per month. These will be virtual, multidisciplinary clinics, and we can talk a little more about it, but even our hub is virtual and multidisciplinary, so we will have participating experts for the hub from different sites across the country, and the spokes, I hope, will be all over the country. But really, even this distinction between spokes and hubs is artificial, and our hope is to really follow the original model that all will teach and all will learn through these case presentations and didactics. 2 clinics a month, 1 hour each. Our plan is to discuss 1 or 2 cases per clinic, and each clinic will be completed with a short didactic. Our plan is to develop a library of these didactics that I hope will be housed on the ASPEN Online Learning Center. And as I said, we'll provide free CE credits. And our plan right now is that we'll have a project coordinator. Hopefully we will get around to grant funding that will fund a clinical coordinator, but for the moment we're sort of all wearing different hats for the project. But we will triage and coordinate the cases that are submitted for presentation to follow also hopefully a good learning trajectory. Cases will be presented to standard templates that we are in the process of constructing, and our mission will also be, apart from the general discussion from the case presentation, we will have a commitment that the multidisciplinary hub will provide specific recommendations to the presenter on completion of the clinic. We can discuss this further, but the ECHO clinic is a fully HIPAA compliant virtual clinic, and therefore participation is not open directly to patients. Our strategy, this is somewhat not relevant perhaps today, but we've got some seed funding from Mount Sinai, from Zealand, as I mentioned, and from the OLY Foundation to get us started. And we are, as soon as we can breathe and get this project off the on the grid and off our drawing boards, our hope is to apply for extramural grant funding. We've identified some sources. We are reaching out to clinicians at home care companies. We're interested particularly in non-specialist physicians at medium-sized hospitals who either encounter patients on TPN and feel less comfortable than they would like to be, or indeed want to just be a resource to their local clinical community, whether that's a hospital, whether that's a home care company, whatever it is. But it's open to clinicians, and we the mission of this project is to support clinicians like that and to feel that I have access to a multidisciplinary expert team right behind me. And I mentioned research in passing. We certainly intend to study what is the value of participation because I recognize that we're going to be asking busy clinicians to devote to us a month. And while that might seem very little to many people, I recognize that that's a big ask. Everybody is running around trying to get the day's work done, and there's not enough hours in the day. But I hope that there will be enough value, that the value proposition is real here, that for 2 hours a month, and we ask for a minimum commitment of 4 months, so that is 8 hours over 4 months, we hope that participating clinicians would have gotten enough out of it. We have an idea to do a cohort study for a prospective cohort study for a quality of life, which we've identified the tools, and we can talk more if there's interest. And we're already in discussions to launch if you like, a child of lift, yes, a pediatric project. For the moment, while our focus is predominantly adults, it's not exclusively adults, and we would welcome pediatric cases. Some of the challenges and problems are similar, and it may well be that the community is best served by doing a combined clinic. What can you do to engage? You, the clinician, please participate. We ask that you commit to a minimum of 2 hours per month for 4 months. As I said, that'll be 8 hours in 4 months. I ask that you consider submitting cases for presentation, and really, you're here already, maybe you're interested, I hope you're interested, but when you engage, when you sign on, participate in the case discussions. This is really, it's an opportunity to have a safe academic environment where we can talk to each other over these complex cases, and then engage and spread the word. You know, reach out to colleagues who might be interested, tell others about this. And this is still an idea in evolution, but my hope is that once clinicians complete an initial module of 4 months, for want of a better term, let's call it Intestinal Failure 101, we're thinking we will also do then a monthly ECHO clinic on a sort of parallel track, if you like, that it's open to people who finished the initial 4 months, and that's no commitment, drop in. If you want to continue your, I don't want to call it training, but if you want to continue your lifelong education in this fascinating but challenging area, treat it like a drop-in clinic, bring more complicated cases, engage in a higher level of discussion, and perhaps a higher level of didactic. And once again, I just want to remind you that that's our website, And there's my email. If I hope I think I have time for questions. I wanted to save 15-20 minutes for questions, which I think I have done. Please hammer me with questions, because some of this is still in evolution, so we really want feedback and critiques. I tell people I want naysayers. It's a little late in the day for me to shut this down, and I don't intend to, but I recognize that naysayers are saying are skeptics for good reason, and we'll listen carefully and see what we can answer. Thank you all. Thank you for spending time today on this, and I hope you will join the effort. Thanks, Andrea.
Thanks, Dr. Iyer. We now welcome any questions anyone has for Dr. Iyer at this time. If you haven't already done so, please feel free to submit your questions in the question and answer section of the dashboard. So we will move on to any questions.
Somebody has a question.
Do we have any questions for Dr. Iyer?
Shell-shocked. So if I may, I have a question. Can I hear from at least one person who is thinking of joining this? Okay.
Nothing at the moment.
Nobody, perhaps. But I hope I've given people food for thought. You have my email. Email me if you have questions. Email me if you have concerns. Or email me to tell me what you see as a problem and why you might not join.
Absolutely. And for more information on the ECHO program, please feel free to read the featured article, Introducing an Innovative Model for Education and Patient Care by Marion Winkler, Kelly Tappington, and Kishore Iyer in Oley's January-February issue of the Lifeline letter. We now have a web page on our website dedicated to the Lift ECHO program, so please check that out. And the third link you see down here is the website Dr. Iyer mentioned earlier, www.liftecho.org. Thank you, Dr. Iyer, for an excellent presentation. We appreciate you sharing your expertise. Thank you also to the participants for joining us today. We'll post a recording of the presentation on the Oley website in case you'd like to view it again. We hope you'll join us for another webinar. We do have Dr. Iyer and Kelly Tappington presenting on the Lift ECHO program on April 23rd at 1 to 2 p.m. So we hope you can join us. Dr. Iyer, we actually, believe it or not, just have a question coming in if you'd like to take that now.
Love it.
What would you consider to be the most important piece of managing intestinal failure?
Okay, that's a tough one. That is a question that is trying to capture the 8 sessions of Lift ECHO in one question. But it's a valid question, and I will do my best to answer it. I do think maybe, and I'm not being coy or cute here, we know that intestinal failure treatment is very, very challenging. And therefore, the single most important thing of managing intestinal failure or home TPN, and I use the terms interchangeably, the single most important thing is having a multidisciplinary team. And I have the benefit that I'm in a center, I'm in a program where I have such a team, but I'm very, very mindful that many clinicians around the country don't have access to that team. And in some ways, that is their challenge when confronted with a complicated patient with an abdominal catastrophe or somebody who has no bowel and is needing TPN. You don't have, if you're a primary care doc and maybe you have only one such patient in your practice, and you think, what do I do with this patient? I'm in upstate New York, 9 hours from New York City, and I'm stuck with this patient. And you do the best you can. And that is really the gap that Lift ECHO is trying to fill. to provide a clinician like that with the backup of a virtual multidisciplinary team. Look, I've been doing this. I've been managing intestinal failure for 20 years. I'm a surgeon, but I can manage TPN. I trained in it. Over the years, I've acquired some experience. I'm a transplant surgeon. I can do a transplant. Our goal is not to make non-specialist clinicians transplant surgeons or even surgeons. Maybe you're a general surgeon who has an interest, and there's no reason why you could not do some of the common things that we do for these patients, which might be well within your scope of practice. But let's assume for a moment you're a community gastroenterologist. I said Syracuse, New York. In Syracuse, if I had to manage somebody on HPN, I would struggle to say, who do I call who can help manage this patient locally? That's a real problem. In all of New Jersey, there are 1 or 2 clinicians who manage patients on HPN, and those clinicians' access in terms of insurance, in terms of reimbursement, etc., becomes very problematic. I'm managing patients on TPN in Pennsylvania, in New Jersey, in upstate New York, Vermont, Maine, New Hampshire, so many such places. And the idea is simple nutritional management, simple medical management, and possibly even TPN, depending on your underlying specialty, is feasible and is doable with support from a multidisciplinary team through ECHO. And just to come back to the answer to the question, that multidisciplinary team is the most important thing in the care for intestinal failure.
Excellent. We do have another question that just popped in too. What case type of patients tend to fit into that 20% that benefit from transplant?
Whoever sent in that question, it would be such a shame if you do not sign on to Lift Echo. You've got the right question, and sometimes those are challenging questions. But as a general guide, we would say, we don't simply transplant patients who are on TPN for quality of life reasons. There are many patients who are leading very good lives, full, productive, good quality of life. They're able to work, they're able to go to school while on TPN. Several years ago, when Medicare was trying to decide who should go to transplant, they recommended, and they're only recommendations, they're guidelines, they recommended that patients who are having complications on TPN should be considered for transplant. So Medicare actually said there should be 2 sets of conditions that are fulfilled. Number 1, the patient should have refractory TPN dependency, or in other words, irreversible intestinal failure. There's no opportunity to come off TPN. And number 2, the patient should also have TPN failure. What is TPN failure? It's the onset of complications. The common ones are related to the catheter-related infections. And Medicare said maybe more than 2 infections in a year, or even 1 fungal infection, which can become life-threatening, might be an indication to consider for transplant. Or the onset of liver disease in the setting of TPN can become an indication for transplant. I must say, as the outcomes for intestinal transplant are improving, we are definitely starting to see patients and transplant some patients even earlier for purely quality of life reasons. That's potentially controversial, but we, at least our center, is definitely considering some patients, and that's worthy of more discussion. But if somebody asked me, would you transplant somebody for quality of life reasons? Possibly. That's the answer. Thank you for that question. Important question.
Excellent. Okay, do we have any other questions for Dr. Iyer? Okay. Well, again, we'd like to thank you for participating and joining us today. We will post a recording of the presentation on the Oley website in case you'd like to view it again. And as I mentioned before, we are having another webinar on the Lift Echo program with Kelly Tappington and Dr. Iyer, and that's scheduled for April 23rd at 1 to 2 p.m. We hope you enjoyed the webinar. Again, thank you to Dr. Iyer, and that's it for today. Have a great day. Take care. Bye-bye.
Thank you all.